Yeah, I thought it would be a good opportunity to talk to everybody, kind of a little bit about a couple things that we do, or we've been doing a little bit more and more often. I know that Dr. Ryken used to do this, and I do it, and certainly Dr. Kinsman and Kimmel do them as well. And so I figured, more than just the spine team, we could kind of tell anyone who may help out with positioning or may even come by and give a break or something like that, kind of what we're doing and why we do it, and a little bit about positioning and all kinds of things like that. So this is a pretty basic talk, but hopefully it'll shed some light on why we do things from the side rather than the front or the back and that kind of stuff. So as she said, lateral trans-psoas approach, or lateral lift, or X lift, or D lift, or extreme lateral lift. Those are all the things that we call the lateral approach in spine surgery. And so a little bit about the history. About 2001, the smart guy said he was tired of going from the front where there's a bunch of big blood vessels and dangerous things, and we typically need vascular surgery to kind of bail us out as far as getting us the approach. And he also said he's tired of going from the back because, and we'll get into it a little bit later, but it's really difficult to get a large cage or what we put in the disc space to help us with fusion from the back, because there's those little things called the nerves that are right in your way, and so you kind of have to avoid damaging them. And so he started working with cadavers and said, hey, what if I come from the side? How about that? And people thought he was crazy, and now it's pretty common practice, and we can use it quite frequently to do a lot of things, and hopefully I can shed a little light on that today too. But it's certainly a great alternative to anterior or posterior surgery. It's also a really good adjuvant when it comes to deformity surgery, because we can really balance people's spines out, particularly if it's due to degenerative disc disease and things like that. And so I briefly touched on it, but there's a lot of reasons to do it. For degenerative disc disease, it's probably number one. And also spondylolisthesis, or slipping in the spine, as well as deformity. You can do it in spinal stenosis. As I said, degenerative scoliosis is a really good one. Non-unions, and we'll talk about that because of the amount of cage that you can get in there. It certainly provides you with a large faceplate for fusion across two bony surfaces. Trauma, and then infection. Infection is probably the lowest, just because we attempt to avoid certain things, but it could bail you out if you needed it. And so here's a perfect example of why we would use it and what we would do it for. And you can see here that, at this, do I have a laser pointer? Oh.
Yeah, you do. It's on the top.
It's all right. So you can see here, I'll just walk around. I'm all mic'd up anyway. As you can see here, this degenerative disc disease is a little bit flatter. Okay, and when it gets flat, not only does it kind of crunch down and the hole of the foramen in which the nerve comes out gets pinched, but also when it flattens out, it goes from a pillow to a pancake, and so you don't lose surface area, so it's got to go somewhere, right? And so when it does that, it kind of squeezes out in the back or in the foramen. And so, this is looking at the spine from the side, and this is looking at the spine if I just cut into a bunch of slices and look down. And so you've got the disc in the front, here's the spinous process in the back. Attempting to show where the dura, the nerve roots are. And you can kind of imagine the disc is kind of flattened out and it's kind of squeezing back here. And as those nerves come out, it's pinching them as well. And so, whenever I talk to the patients, I'm always talking to them about literally when they have degenerative disc disease, how it goes from a pillow or a marshmallow to a pancake, and what that causes. It doesn't just cause it to bulge back, but it also causes compression in the hole or the foramen in which the nerves come out at. If you can imagine that. These discs really do act like pillows and keep things open, and so the nerves have room to come out of the foramen. And so if you can imagine that, then you can kind of see the idea behind what a lateral or a large cage of any kind would do, I'll try and stay on track and just talk about laterals today. And so, there's multiple benefits of going from the side. You don't disrupt too many tissues. You get really a lot lower blood loss, or you should, because you don't have to do that taking down of all those posterior elements like you see most of us do who do spine surgery. Initially, the first, depending on how big your case is, the first 30 minutes to 2 hours is literally just dissection if you're going from the back. And so you don't have that. There's a lot less post-operative pain because we can make an incision about the size, of half of my pinky in length. And then less blood loss, less damage to tissues, less post-operative pain equals a shorter recovery time. And like I said, you don't denervate the posterior musculature because you don't have to take it down. You don't have to pull on the dura at all, so you don't have to worry about getting into that or messing with the nerves too much. And we'll talk about other reasons that we can avoid that in a second. You don't destabilize anything because you don't mess with the joints per se, so you don't take down the ligamentous capsule. It minimizes the risk of vascular injury because we're not coming from the front. And then, like I said, you retain all your structures, and so you're really keeping a nice compact area in which you're working, and so that's nice. And then the biggest thing is obviously allowing for a large area of disc to be removed and replaced with some kind of graft, which hopefully will facilitate bony fusion. And so that's nice. So again, the reason it says XLIF on here is some of these slides are from NuVasive because they've got the best data on it, but don't be fooled. XLIF, lateral, DLIF, they're all the same. So you can see that the top things are blood loss, obviously, hospital stay compared to your regular TLIF, or doing everything from the back and putting in a cage is about 1 to 3 days versus on average 3 to 6 days. I would say that a TLIF nowadays is probably more 2 to 4 days rather than 3 to 6. And again, walking, a lot of people don't feel like walking after you blast through their back. But Dr. Reichen used to attempt to do some of these same day. I typically tell these people that they can walk around as much as they want, but they'll be here overnight just so I can watch them. And then obviously when you're talking about hospitals, it's always about the bottom line. So we talk about how much things cost. If you cut down your length of stay, then you can cut down on your costs. It's essentially what that shows. And so things to worry about, not everyone is a candidate for it. You got to look at your preoperative imaging. On the left, on the x-rays, you can see there's a little bit of, that's a perfect example of a patient that would do great with this. There's a little bit of a degenerative scoliotic curve. They're kind of breaking down just a little bit. They've lost disc height here compared to this one. You can definitely see the difference in height, and actually here too. And so with the lateral, you can straighten that spine out, and you can definitely give them the space that they need. Here's that spondylolisthesis at that level, and you can straighten that out as well. So that makes someone an optimal candidate. The thing about MRIs is it'll show you not only the nerves and the discs, but it'll also show you if you can even do it on someone. And so if you're coming in from the side, if you can see these little arrows, it's essentially this is how you'll be coming in. If you have down at 3-4 and 4-5, if you have the psoas, or what is the filet mignon in cows, because they can't stand up, so it's very tender, so it'd be really chewy, is around the spine, and it's what allows us to kind of pick our legs up like this. If you have that kind of compact right here and laying down flat like that right there, then they're a perfect candidate. If you have what looks like Mickey Mouse ears and they're kind of sitting up here, that's a no-go. Okay, that means that their muscles are a little bit anterior and there's nothing but nerves in your way. And so the thing that you want to avoid is nerve injury rather than barreling through and giving someone some serious problems. And so you got to look at your MRIs closely and realize who's a candidate for what, and understand why we do things. And again, you know, there's a lot of spine surgery out there, just in general, particularly in the big cities, and it's not always, you know, that they're doing the wrong thing for a patient. They may have the right idea in mind, but if you do the wrong procedure for the right idea, you're going to get the wrong results either way. And so you got to realize who's a candidate and who's not, and it's really cool to make a small incision and potentially have a quick surgery, but if you have the wrong indications for it, it's going to fail also. And so the big key steps, as you guys who's been in my room, or I'm sure Dr. Kimmel or Dr. Kinsman's room, or previously Dr. Reichen's room, is positioning is like number 1, 2, and 3. Because if you set up your position just right, then you can set the stage for you to go fairly swiftly and safely. And those are the two most important things. Obviously, once they're positioned and you've cleaned off their side, then you'll get your access, you'll dilate, and then the quick part is just doing a discectomy and sliding in that cage and trials and placing it permanently, and we'll kind of go through that real quick. So when I lay someone on their side, I'll sit there and tape them down, and then I'll literally get x-ray to come in, and we'll shoot like 1,000 shots, and you guys are probably like, why is he radiating me today? This is not great. But you know, that's because you want to have these two pictures as best as you can. You want to have those crisp end plates and see the disc space perfectly. You don't want any kind of double picture, if you will, in which you can't see exactly what's going on, because you want to know the anatomy perfectly. Because if I'm just a little bit too forward, I'm in their belly, and I could be hitting their aorta or something bad that I can't fix. If I'm just a little bit back, then I'm messing with their nerves. Okay, and that's what we're trying not to do. And so you got to know exactly where you are, and the pictures are your only way, because you're not going to see anything other than the x-rays. Your incision's this big. Sometimes I operate on people the size of this podium. You know, you're trying to make things work. You got to use the x-ray to do everything. So you might as well set the stage before you start operating, rather than, you know, turn the table away from you, turn the table back, that kind of stuff. Like I said, this is the way we tape them down. We typically use the regular operative table in reverse. So you can break the bed right here. And so you put their hip or their pelvic brim right on top right there, okay? And typically L4-5 is going to be right here where this stops. And so that automatically tells you right there that if someone's got a problem in L5-S1, you're not going to be able to get to it. You're just going to bang right into the bone. So usually we use L4-5 up for laterals. If you break the bed, you can kind of get them open enough so that you can come down at L4-5. And again, we'll talk about a little bit in a second, but the nerves are kind of a big thing too at L4-5. And so that's why people for a long time only did above 4-5. They did 3-4, 2-3, 1-2, that kind of stuff. But typically this is how I tape the patient down, and then I'll have the x-ray come in, and I'll start moving the bed. I won't move the patient. And once they're locked in, hopefully they're locked in as straight as can be, you start taping them down, and you start rolling the bed one way or another to get those views so that it looks just like that. So you can see straight on, you can see the pedicles here. There's no double lines anywhere. You can see the end plates, you can see the pedicles here. Nice crisp end plates right there. So you know exactly what you're getting when you're getting it. Now, if I ever had a picture this clear, we could probably go a little bit faster than the way I go. But so here is the way it usually goes. So you have the patient facing away from you. You have x-ray come in. You've got Chad or Jason down below, or any of the other folks that help me out a lot. But those two are usually the ones that are stuck with me because of Vanessa. And then you have your retractor, and then you go in and you go from there. And so it's a fairly clean and nice procedure. You set up the room and everything like that appropriately. Again, pre-op, I'm sitting there marking off everything. I'm writing all over the patient. I'm trying to figure out which level I'm at, where I'm going to make my incision, all those kinds of things. As you can see from this picture right here, there's a lot of bad things in there, and so you want to avoid all that stuff and just go retroperitoneal. And so when you come down, you literally come in right where this thing is. You make a little incision right here. And once you get past this, you try and stay out of the peritoneum, which is what houses all the bowel and bladder and all that kind of stuff. And you just kind of come down with your finger and get around here. You can excuse me, you can feel the bone a lot of times if they're small enough. I mean, I got pretty big hands, but you can get down there. If they're too big, you can't do it. You just got to base it all on kind of feel and your x-ray and your retractor, but you're coming right down through there, and you're not going to cut the psoas, you're just going to split it, and you're going to dilate it, and we'll talk about that in a second. So what happens is you put down a little monitor, if you will, right into that disc space, kind of right in there where that X is, and you lock it in and you get an x-ray, and I think, yeah, there you go. So you put it in like this, and so this is what your x-ray should look like. And so you've got this little dilator, and this dilator is in the disc space, and it's telling you whether there's a nerve or nerves, because there are a bunch of big bad nerves that live on top of the psoas or around it. And it'll tell you how safe you are, and you can spin that dilator. And what it'll do is, depending on where this dilator is, if it's there, then it'll tell you, yeah, all the nerves are kind of behind you and you're fine. If you happen to come down, because remember, you can't see any of this. So if you are coming down here, it's telling you that's bad. You're way too close to a nerve. And if you start to open things up, you're going to cause all sorts of damage. And it's usually ringing off the chart in red, or the neuromonitoring people that are in the corner are telling you, no, this is not good, because the threshold is very low, because essentially it sends out an electric pulse or charge, and when it does that, depending on how long it takes to get a stimulation back, you can see how close you are to a nerve. And so, you want to be in front, or if you're like in a safe place there, far enough from those nerves. And sometimes you'll start the case and you'll put that dilator down 10, 15 times, and it just will not go, and you got to bag it, because you can't take that chance of them waking up and not being able to pick up their foot or something. That's not what you're in the business for. And so you got to definitely find a favorable position. But a lot of times what will happen is, again, those nerves kind of live within the muscle, and they'll just go around and do what you want. So you'll put it down, and it'll say, no, that's a bad spot, and then you'll just move it just a little bit, and everything will just fall into place. And so that's kind of nice. But when you put that probe down like this, you then take these dilators, which are essentially larger size tubes, and you just lay them down on top of each other. And so you've got your one spot, and then it just slowly opens it up wider and wider and wider. And as you put that down, you then put down your retractor itself on top of that last dilator, and you should get a picture like this. And so you can see that retractor is kind of coming down, and what happens is I'm going to open it up, and so when it opens up, it's going to be like this. So all the muscle, all those layers, all the retroperitoneal tissue that you can see on that picture is out of the way. Now I'm looking straight down at the disc space. And so that's a nice thing when it works. A lot of times you'll get a little muscle creep, and you'll just have to kind of move that out of the way, or potentially just kind of burn it out of the way. But here's the picture from the straight on. As you can see, the retractor is in there, and you've got that pin that's through the disc space, so that you're safe and you're in a good spot, so you can kind of move the retractor around. And then this is what I'm looking at, straight down when the patient's on their side, disc space, and that's that pin that's kind of in there, and the retractor that's starting to open up to show me what I need. And so this is essentially what I see when I can look down there. Again, like I said, a lot of times you can't see much. If this is what you can see, then you're doing pretty good. And so you've got everything out of your way. You got a little bit of bone, so a little bit of end plates, and then disc in between. And the X-ray is what you see on my left, your left too. So then what you do is, so you're all set. You've seen everything you need. You're safe, and you know now that you just got to trust the system because you did that neuromonitoring beforehand. So you'll put a cob in and kind of break through that disc, and you'll go through on both sides and open it up, and then you really just perform your discectomy. So you take all the disc out of there if possible. So you can see, since you're safe and you got that big open area to just get all that disc out, how much easier and how quickly you can do a discectomy without worrying about those nerves that are in the way, like when we go from the back. And so that's a really huge benefit, and you can get a lot of disc out in a short amount of time. And you kind of prep those end plates or those two bony surfaces for fusion, rough them up a little bit, and then you try different size cages, and then that picture that you can see over here on the right is what those cages typically look like. And so see how big that is? I mean, that's huge in size. It takes up the entire width of the disc space and about 2/3. And so that bony fusion mass is now triple what you can get with doing something from the back easily. And you can also imagine that if I have an angle or a wedge, I can easily open things up and give the patient more curve. And that's really important, whereas in the back, you just typically get a little tiny cage in. It's probably about the size of my hand in comparison, and you won't get any curve whatsoever. You'll help with fusion mass, but nothing like that. That's money right there. So it really helps quite a bit. So you can open them up quite a bit. As far as earlier when we were talking about those pillows becoming pancakes, you can really prop them back open, and they can do quite well. Here's just a comparison. The A-lift is when you come from the front. Again, when you're coming from the side, you don't have to worry about those big blood vessels. You don't have to get Dr. Kuya out to come in and bother the spine team and all that kind of stuff. And so, an A-lift, you can get a pretty big cage in there too. But again, you can only do an A-lift at 5'1" and 4'5", or else Dr. Kuya, Dr. Stark have to start moving those big vessels. I did an A-lift yesterday, and he does it all the time, but he nicked a small vessel or a big vessel, and we lost 800 cc's of blood in about 10 seconds. So that makes me sweat a little bit, but he just sits in there and does his little thing with his PDS. But, we avoid all that from going from the side, and so that's a really nice thing. And again, you can either take a vascular surgeon in there with you to go from the side, like Dr. Riken used to do with Dr. Stark, or you can go in there yourself, like some of the young guns do now. But, I think either way, you can see kind of what a lateral can hold for you. It's certainly as large a cage as an A-lift, and that's really, really nice. This is what it looks like when you're inside there. That's that cage dropped in on somebody, okay? And this is what happens when I'm looking down. And I say, oh, we're all done, let's take it out. So you slowly close down the retractor and you pull it out to make sure there's no specific bleeders, because there are some things that will bleed. And then last but not least, the thing that everyone cares about is if you get pretty facile with X-lifts, the amount of time it takes to do them and do them well is a lot shorter than doing it from the back. So just don't have to take down near as much stuff. I would disagree on the A-lift OR time. That's all about your access surgeon. Dr. Kuya and I, in general, can do one skin to skin in like an hour, hour and a half. But still, there's a lot of other issues with going from the front. EBL obviously is very low because you're avoiding a lot of the bad things and or taking down all that stuff in the back. Length of stay, again, I would disagree with the A-lift. They've come a long way, and they're about the same as your length of stay from the lateral. Complications are improved. Neuro complications are improved, which makes everyone happy, and then reoperations are pretty low. And that's it. Any questions? Oh, a lot of questions.
Do you normally go from one side or the other, or is that patient
So it's a little bit patient specific. Perfect example is, sorry. So here, perfect example is here, you know, on this patient, I would try to go on the side that's more open. So you can make, it's not much, but you can make your life a little bit easier, particularly when you got a little bit more of scoliosis than just that. You're trying to go on the open side. But you know, the higher up you go, you need to start worrying about the liver and things like that. So it really all depends on the patient. And sometimes they have a tattoo on their side or something silly like that, and you just avoid it. So it's kind of specific for each patient, but in general, if I have my choice, I'll just put their left side down. It kind of makes the setting up the room a little bit easier, but it is what it is. Yes, ma'am. Oh.
I'm sorry. You schedule it which side so we know which way to turn it around?
Yep, I do. I say which side up. Yeah.
So how many levels do you do?
So you can do one, and that's nice. The thing that I've been doing the most is for these patients that have a large deformity, is what I'll do is I'll bring them in on Monday, and I'll do like 3 or 4 laterals on them to start setting them up for a big case on Tuesday or Wednesday. So I'll typically do like L1 to 4, so 1, 2, 2, 3, 3, 4, maybe 4, 5 from the side, and then put them on ice, let them hang out upstairs, and then the next day take them back and do like a T10 to pelvis or a T4 to pelvis, because you can avoid doing a lot of osteotomies that way so that you lose a lot of blood the next day, so you kind of set the stage for yourself. But there's some great, like this candidate right here, this x-ray right here, there's some people who would just be a 1 level and boom, and they're done. So you can kind of use it in your armamentarium, either that to kind of set the stage for big cases, or you can just do it on a one level type picture.
If you do multiple levels, do you have to move that cannula to dilate?
Yep. So you have to do each one. Remember, you got to put that thing down and say, hey, is it safe to go here? Yeah, it's safe. Okay, cool. Now I'm going to dilate and do it. Again, there's guys that do this all the time. The one guy that trained me, he can do one of these things in like 25 minutes, like total. So if you're really good at it, and you have the team like I have that, that everyone knows kind of by now what myself and Dr. Kinsman and Kim will do. They set up the room and things like that. Like if you're really good, you just come in, make the incision, boom, get down there, do it, and get out and close them up. Because you're only closing up an incision like this. So it's pretty quick. It's all about, like I said, prepping, taping the patient down, getting the x-rays right, and then you can just fly. I'm not that quick, certainly, but if you're that fast, then 20, 25 minutes at each level is still done in like an hour and a half doing 3 or 4 levels. It's pretty slick. Yes?
Is there a weight restriction?
Nope, there's not. There are, so when you do pre-op planning, you got to figure out the longest special made retractors are 19 centimeters. I know because I had to call them in from San Diego. And so that's a restriction, right? If it's too much to get to, then you can't do it safely. Because if my retractor runs out and then all those structures are in front of me, that's a nightmare. And so that's the usual thing. And in order to tell that, usually someone will have a CT scanogram of some kind or an MRI of some kind, where they just have that scan of your whole body on the outside, and you just measure to get a gross idea of how it's going to be. Now, some of that stuff sloughs away when they're on their side, so it's not a perfect picture, but 19 is as big as it goes. And I've done, as of late, like 15, 17, and 19, and anything over 15, you're really struggling to get a good sized cage in and feel like you're safe. Again, your finger dissection is lost. So you gotta, again, it's all about patient selection. You gotta remember what's good for someone may not be good for someone else. Yes, ma'am.
Have you ever had somebody in position and everything was perfect and you can't get a good reading with the cannula
Yep.
or marker? So what do you do then? Do you
Pull out, close them up, flip them on their belly.
Okay.
Yeah. And the other thing is if you have too much stenosis in the back, so a lot of times you guys will think, oh, we just did a lateral, why are we going in the back now? So if you have too much stenosis in the back from arthritis back here too, you can open them up with a lateral and do all those things to kind of open those channels. But if you have that stenosis midline, they still need a decompression in the back. And that's why I'll flip those people on their belly and open them up and or put screws in the back for more of a fusion, if you will. So you just feel even better about the construct. The number one complaint from these patients is whatever side you're going through, because you split the psoas, about 20 to 35% of people will say that they do not like doing this post-op. Remember, the psoas does that hip flexion. They say it hurts, and you say, I know it's going to get better over a 3-month time frame. But essentially, when you split their muscle, you give them a sprain or a strain, right? And so some people are like debilitated by it. They'll say, this is awful. This is terrible. And you just say, spine surgery sucks. We'll get you through it. Like, I promise. But all jokes aside, like that's a serious, there are people that completely forget about their leg pain, but that's all they can concentrate on. Yeah, my legs doesn't hurt anymore, but this is terrible. Every step I take, this hurts. And so again, that's the thing. I start telling them in the office, and then pre-op I start reminding them again, remember we had this conversation, you may be one of those people. And hopefully it gets better in a 3 to 6 month time frame.
So is there any age restriction either, or do you go in and do any redos?
Well, there are no age restrictions. Another thing that people will get a little bit worried about is when you start seeing those films and you can see that their entire aorta looks similar to their spine. It's all calcified in the front. So when you see that, remember, you could have a 55-year-old person like that, or you have a 90-year-old person like that. But when you see that, you start getting a little worried that if I crank open the front, that their vessel may be so calcified that I crank open their vessel too. And so people get really worried, or if they have really sharp, severe osteophytes in the front here, and you crank that open, you worry about those vessels too, because those vessels lay right on top. So you want to be safe with that. The redo factor is, if someone has a lateral, unless you put it in recently, like, you're not going to go back in and pop that thing out. Very few people will do that. You'll have to do it either from the side, from the back, or just low enough from the front. But the other option is to use that in your revisions. And I know that I've done it, and Dr. Kimmel has done it. If someone has a posterior spinal fusion with a bunch of screws and a ton of scar tissue down here at 4 or 5 and 1, and it's some system that Dr. Jackson invented and no one knows how to get it out, ask me how I know. They have this. They've got like that adjacent segment disease, that level above. Well, boom, perfect, right? I don't have to put in more screws and take up his fusion before and do all kinds of takedown of structures in the back to find where his screws are. I can put a lateral in just above it and hopefully get all the things that I wanted from it. So you take that fusion up a level. You may have to go in the back above where he or she was before and do a decompression like we talked about, but you don't have to start worrying about what kind of screws it is and taking out some or all the old hardware and or extending it up. You can extend it up easily like that. And so that's really nice. Like I said, I know I've done that. I know Dr. Kimball has done that, and so that's one nice thing about it. Any other questions?
You've done stealth with a lateral before having
Not here. In LA I have, but not here. But you can do stealth with the lateral. Medtronic allows for that. And so, again, that's just another added safety bonus. The thing about doing stealth with the lateral, that why I would do it, is to keep them on their side and put in screws on their side. So rather than say, okay, everybody, we set it up, we set the stage for the lateral, we did the lateral, now we're going to flip onto our belly, and everyone who's helped out in my room knows it's just an absolute poop show when we do it, right? If we go from laying supine to prone or going from lateral to prone, everyone's in there and we're flipping the table and anesthesia's all really freaking out, and depending, especially on if you have the one I had yesterday, he's really freaking out. But that kind of stuff can be avoided, and remember the time. So the 40 minutes or the 45 minutes or the hour, from going from the side, taking off all the tape, laying them and being safe, padding up everything and going prone. You can keep on their side and say, okay, I'm going to shoot screws on their side and lock them in. So if I did a lateral here, I could shoot screws while they're laying on their side. I've done it with x-ray before. It's tough. It's definitely a learned skill. I'm getting better at it. The first time I did it, it was a nightmare, but you got to keep doing it to get better at it. But if you did it with nav, it would be real slick. And there's some guys in LA that did it with nav. I'm sure there are folks out here in Kansas City that do it like that as well. But I've not done it with nav, but I know you can. I think that it's probably more of a Medtronic thing than anything else, because of the nav kings right now. But you certainly can do it as an added safety bonus. Other questions?
Do you think you'll start doing them, or do you still want to stick with NuVasive?
Oh, so you touched on a touchy subject. Trudy's not here, is she? This is a safe haven. So I use Medtronic only for my laterals, because NuVasive's naughty and are too expensive for the North Kansas City population. That, and NuVasive's got this little funny thing like we showed earlier. It's cool because you don't have to call in the neuromonitoring folks. You essentially do the neuromonitoring yourself. And so you get that when you do that probe that I talked about, you have this little station that they tell you to put. There's the NeuroVision, that's that little thing right there. You have this little station, and when you put it down, it literally, this is the screen that you see. And so green, all right, we're in a good spot. Yellow, we're pushing a little bit. Red, got to reset. And you can read it yourself, and you take the thing and you just kind of spin it so you're facing forward, and you say, up, green, facing back, yellow, green, okay, we're safe to go. Because you kind of have an idea of where you are based on that. And so they cut out the neuromonitoring folks. The physician does it himself. Now, that little box probably costs, an arm and a leg. And so I was told, whoa, you can't be doing that. You cost way too much money. So I said, okay, we'll stop doing that. We'll start doing it, the way that it was set up. So, K2M is a nice system that I know that Dr. Kinsman and Dr. Reichen used to use. Dr. Kimmel's finding which system he would like. I'm sure Anessa could tell you that better. I know he's tried Globus, and then I use Medtronic, just because the rep is really good. They have a good system. It could tie in with doing things with nav, and also they've got a nice posterior system. And again, I typically do things lateral and posterior at the same time. Yeah, you cannot. I am not allowed to use NuVasive here. Only at those HCA facilities that I sometimes frequent am I allowed to use their stuff there. The problem is, just to divulge the honest truth, is NuVasive system was the first, and so it's the best. It's probably the best. They've got all the little patents on all the nice little cool things, and people are trying to get around that. The most recent Medtronic retractor that I used, it was very similar to the NuVasive one. It was really nice. But the one before it was just dog meat. You know, you're like, this is not that great. But we're getting there with other systems. They're all catching up. So either they'll have to lower the price or, buy Rhonda something special. So, we'll get there. But, I don't use NuVasive here. I use Medtronic. The other reason that you use certain companies is what the implant is itself. Medtronic and NuVasive have really large degree wedge cages. And so for what I do and what I like is to make sure that we always restore, let's find a good picture of it. You always want to restore this curve on patients, right? You don't want to fuse them flat. You don't want their lateral to look like this, because they're going to get back pain and they're going to need some big procedure to give them a curve. You want from this end plate to the top of L1, so from L5 to L1, you should have 45 to 55 degrees of curve. And we lose that with degenerative disc disease over time and arthritis and things like that. And that can lead to flat backs, that can lead to pain, that can lead to people like this who can't stand in front of the mirror for longer than 5 minutes without having to lean over because their back is constantly, all those muscles are trying to pull you back up so your chin is above your belt buckle. And so if you're trying to restore that, they can give you a little cage from another company with 5 or 7 degrees, which is really going to get you like 3 or 4. Or, that's where NuVasive took off. They said we got 15, 20, 25, 30 degree cages. You can really crank them open and pop them open. Medtronic said, hey, we're missing out, so why don't we do 16, 21, 26, that they're just off by 1. It's kind of funny, but obviously someone's got the patent. So they're just off by 1, but they're big. You can crank them open, and so that honestly is probably why I use Medtronic or NuVasive more than anyone else, the retractor and the fact that they have those large degree cages. And so, whenever you're trying to, if you're doing it, someone asked earlier, do you do this on one level surgery? Yeah, you do, but you got to keep in mind the whole lumbar spine if you're doing that, or else you're going to get them flat. And the good spine surgeons in the past didn't understand that, and so now we're having to go back and revise all these people who are fused straight up and down, and or the level above will break down. Every time people get worried about this, they say, oh, I don't want to have a spine fusion, because then, grandma's brother's friend, he had spine surgery, and then he had it a week later, and then he had it 2 years later, and then another year later, and they kept hiking the ladder on him. We've realized that a good way to avoid that is restoring your natural curve. Again, that's at 45 to 55 degrees. And by doing that, you can put the level above it at less chance of breakdown, or the level below it at less chance of breakdown. Still has a chance to break down, but it's not the same as that what we see over that 6 to 10 year window that a lot of people that get fused flat will run into. Any other questions? Thanks again for being so attentive, and enjoy the donuts.